Bismillahirrahmanirrahim. Today, I'm going to present Dr. Nafisa from National Guard Hospital, Saudi Arabia. Dr. Nafisa is a distinguished Sudanese oncologist whose insight and experience have made her a distinguished oncologist in the field of oncology in Saudi Arabia and outside Saudi Arabia. She's an expert in breast lung cancer. And it was to say that she has previously shared her knowledge and experience with Sudanese residents, helping to shape the next generation of specialists in Sudan. And she's assistant professor at King Saud bin Abdelhafiez University for Health Science. Today, she will be presenting on a critical topic, management of advanced non-small cell lung cancer lacking driver mutation. This talk will providing us with a valuable guidance on this complex and challenging area of oncology. Dr. Nafisa, the floor is yours. You can start now with 10 residents. Inshallah, we'll collect more attendee during your talk, inshallah. Welcome, Dr. Nafisa, and the floor is yours now.
السلام عليكم ورحمة الله. شكرا جزيلا صلاح على ال kind introduction. Actually يعني ده كلام كبير يا جماعة اللي قالوا صلاح ده. وشكرا لكم for يعني being here يعني early morning. وإن شاء الله يكون محاضرة تعجبكم ويكون فيها some benefits. اعذروني ما حقدر أفتح الكاميرا بس المرة الجاية حنقدر نفتح الكاميرا إن شاء الله. بس this is very interactive. وأسأله ووقفوني في any point into you think إنه ما هي clear وكده. أنا هركز mainly على trials هي كلها تقريبا في حاجات the same design بس إحنا هنمشي over them. أنا تقريبا يعني I mentioned ممكن 90% of the most important trial that you have to know them. بس يمكن في few trials you can go back and read about it. بس هنا تقريبا يمكن more than 90% of the important trials that need to be mentioned or you need to know them. Again شكرا جزيلا و let us start. طيب احنا we'll talk about treating stage 4 non-small cell lung cancer lacking driver mutation. طبعا we know lung cancer is a very aggressive disease. 80% of over 70% of the patient it depends from country to country, but 60 to 70% patients used to come in late stage. Patients are very frail, usually elderly, having multiple comorbidities, so the prognosis is poor. Whatever you did for them, still their prognosis and the treatment outcome is very poor. So we used to treat patients with multiple comorbidities, as I mentioned, sometimes ischemic heart disease. Most importantly, most of them, they are smokers, they do have COPD, so they come to you with a critical situation and advanced stage. Performance status is not that great, so you have to be very skeptical in treating them. You have to, we know that in stage 4, we have to consider a lot of things. The most important thing, number one, you have to put in your mind, what is your intention of treatment? So here we are treating the patient with intention of palliative. So your intention here is not to cure. So you have to think carefully before starting any medication. Sometimes you might not be able to treat at all. If the patient came to you with very poor general condition, performance 4, for example, you don't have to treat that patient. Just by sending him to palliative care, you might improve his quality of life, you might extend or improve his overall survival. So think very carefully when you see patient with lung cancer with poor performance status before commencing any treatment. So patient with driver mutation, they are lucky because you give them treatment with less side effect, less toxicity. You know, this treatment will improve their PFS, might improve their overall survival, but we're not seeing this very clear actually with the targeted therapy, and you know the reason. Most of the trials in the targeted therapy, there was crossover. So targeted therapy always compared with chemotherapy. So definitely the patient in chemotherapy, so the best outcome before the last 2 decades, before the introduction of the targeted therapy and immunotherapy to the treatment algorithm of non-small cell lung cancer, we were talking about 10 to 12 months in the best scenario. So introduction of the targeted therapy, introduction of immunotherapy improves the overall survival in PFS. Back to my point, we did not see much of overall survival benefit in the clinical trials, but we are seeing it in the clinical setting, in the real life scenario, because the crossover. So ethically, it's not good to see patient in the chemotherapy arm not doing well, and you just continue to keep him on that arm because you want to reach a good result, and you want to show that this medication is not good and that medication is better. So you have to shift the patient from arm A to arm B because of you can see that those patients are doing better. Those patients, there is clinical improvement. Those patients are having controlled disease, improvement of quality of life, and they might have better PFS and overall survival. So in all the clinical trials of the targeted therapy, there was crossover from the chemo arm to the targeted therapy arm, and this is very important. That is why we don't see in the most of the trial overall survival benefit. So those patients, although they are very lucky, but unfortunately there are few. So the incidence of a patient with EGFR mutation does not exceed 20 to 25%. We have a study here in Saudi Arabia and in Gulf region, in the MENA region. I think the EGFR percentage is a little bit higher, maybe 35 to 40% of the patient. But going back to literature, is in the best scenario 20 to 25%. So patient with ROS and ALK mutation, still they are below 5%. ROS maybe 2%, ALK 5%. So now we do have a lot of targets now. BRAF, we have MET inhibitor, we have a lot of but all these mutations, they are less than 10% in the best scenario. So we have to think of those. So the majority are lacking mutation. So we have to think of those patients very carefully. So what changed the treatment algorithm or improves the overall survival for those patients and BFS is introduction of immunotherapy. So the treatment option, as I mentioned, is palliative, immunocheckpoint inhibitor or IO or immunotherapy, anti-PD-1 or anti-PD-L1. They change the roadmap or the treatment algorithm of patients with non-small cell lung cancer and small cell lung cancer, of course. So we do have anti-PD-1 and anti-PD-L1. Anti-PD-1 there is a new medication, is a cemiplimab, and the old one, nivo and pembrolizumab, and the anti-PD-L1, as you know, atezo and durvalumab. So, and the rest are coming. So PD-L1 inhibitor are less beneficial in patients with driver mutation. So when you see patient with stage 4 non-small cell lung cancer and you want to initiate treatment, but you don't have the result of NGS and you don't have the result of the PD-L1. So it's very critical to commend the patient or to start the patient on immunotherapy or targeted therapy before having the result. The most serious one is to add chemo to immunotherapy to chemotherapy. So the backbone here is chemotherapy. So if you don't have NGS result, you don't have PD-L1 test result, so your treatment, your standard of care is chemotherapy, either dual platinum-based chemotherapy or single agent chemotherapy. This, as I mentioned, I'm always keeping mentioning, depends on the performance status of the patient. So if you think this patient can fit and go for dual chemotherapy, you go for that. If you think the patient cannot tolerate, you go for single agent. But don't start immunotherapy in a patient without NGS result. Why? They don't do well. They don't respond. Usually they don't respond. We know this very well. They will have more toxicity. So immunotherapy should not be given to patient who is having targetable mutation. And again, if the patient is having high PD-L1 but no targetable mutation, so the standard of care here is chemo plus immunotherapy depends on the percentage of the PD-L1. So the message here is don't start immunotherapy in a patient with driver mutation. You need to wait, you start chemotherapy. All of them will benefit from chemotherapy, either single agent or combination. And then you wait for the result of the NGS and PD-L1 test, and you start accordingly. If you get the result of the PD-L1 first and it was very high, don't be excited with that. Still, you need to wait for the NGS test. But if the opposite happens, if you get the result of NGS first and you don't know the PD-L1 percentage, at least you can add immunotherapy to chemotherapy. So what are the factors that telling you how to, or the guidance, what is your guidance in treating patients with stage 4? So as we mentioned before, you have to look for the driver mutation. Is the patient having driver mutation, yes or no? The PD-L1 expression. So the standard of care for patients with PD-L more than 50% is a single agent immunotherapy. But yet we have to, sometimes if the patient is having high volume of disease and the patient performance, the general condition is good, his performance is excellent like one, and you are thinking of improvement of quality of life, you can go ahead and start chemo plus immunotherapy for a few cycles, and then you can omit the chemotherapy and continue with immunotherapy single agent. But the standard of care, the PD-L1 is more than 50%, but this you can go for single agent. But if you want to give the combination, you have to explain this for the patient very clear. If the patient PD-L1 is less than 50%, the standard here is to give IO or immunotherapy plus chemotherapy. سامعني كويس ولا في مشكلة؟ طيب how do you choose chemotherapy? Chemotherapy you choose according to the histology. We know patient with non-squam, you don't go for you go for pemetrexed in combination with platinum, either cisplatin or carboplatin. Patient with squamous type, you don't go for pemetrexed. So how do you treat patient with PD-L1 more than 50%? This is a real case scenario. His son is our colleague in the Department of Surgery. 67-year-old male was diagnosed with stage 4 non-small cell lung cancer. That was back in October 2022. He came to the ER with convulsions and loss of consciousness, and that was witnessed by his wife. He came to ER, underwent CT scan, found to have single brain lesion. Underwent MRI after that. I'm trying to mention the standard. Please, always, if you can do MRI for patient with non-small cell lung cancer, you go for MRI. MRI better than CT scan if you have the choice. If you don't have the choice, you go for CT scan. But if it's a board exam, which one is better? Definitely, you know this, but just I'm trying to stress on certain points. But MRI is better than CT scan. So MRI and CT scan both showed single brain lesion. His performance was excellent. PD-L1 test came as high, 80%, NGS negative, wild type. So what do you think is the best scenario for that guy? Can anybody answer this? شباب سامعني؟
طيب سامعني يا مصر.
اتفضلي.
طيب البيشنت ده ممكن نعمل له أول حاجة هيستروفيزيكال اكزامينيشن ونعمل كومبليت للويرك اب ستيجنج ويرك اب. إذا في افيلابل بيت سكان نعمل بيت سكان.
اوكي.
إذا ما في بيت سكان هنعمل سي تيز تاب سي ديز.
اوكي.
طيب. بعد ذاك هنجي نعمل الميوتيشن، نعمل
الارك
والراس والروز والحاجات دي.
لو ما في
هنمشي نعمل
سكان، لو ما في بيت you do bone scan as well. Don't forget the bone scan.
أيوة وبونس كانيوس. بعد ذاك حنعمل لوكال ثيرابي على البرين، إما نعمل ريسكشن أو نعمل ستيريوتاكتيك بودري شربي. بعد ذاك حنمشي نعالج سيستميك ثيرابي، ندي بلاتينوم بيس دوبلت كيموثيرابي بلس BDL1 بمبروزوماب مونيزوماب.
طيب good, very good. طب why do you want to give chemo plus immunotherapy?
طيب البرفورمانس ستاتس بتاعته جود.
Yes.
والBDL1 هي سنسيتيف للبلاتينوم بيس، فنستخدم الريسبونس بتاعه يكون كويس. in addition to control يعني disease progression.
Okay. طيب. Okay. Very good. Thank you. طيب احنا هنا if you remember the previous slide I told you the standard of care is for patient with PD-L1 more than 50%. هنا we'll see the trial in the coming slides. But هنا the best treatment for him or the standard for him is single agent pembrolizumab. But we said in the patient performance status كويس and عنده burden of disease is high, here you can go for combination. But you explain to the patient this is in a very good way. You don't need the combination, but your disease is, the combination might improve your quality of life, might give us a quick control of your symptoms if he is having symptoms. For this patient, he underwent resection of the brain lesion. There is more very important trial showed that in stage 4 lung cancer, resection of the single brain lesion improved overall survival of the patient. So here, this guy came with a single brain lesion. That is why I just repeated it many times. He came with a single lesion. The lesion was resectable. So the most important, you have to mention that you call the neurosurgery, you consult them. Sometimes in the lesion might be at a critical area. They might not be able. Here you can go for radiation, definitely. SRS if possible. If not, whole brain radiation. Especially the patient is symptomatic. He came with convulsions. So you have to deal with the CNS disease before starting the systemic therapy. So yes, you are 100% right. You do staging, you complete the staging workup. If you have the PET CT scan, this is very good. If not, you go for bonus scan and CT scan. And then you go for resection of the brain mets if possible. The resection should be followed by radiation therapy, and then you go for systemic treatment. So this guy, his NGS was really delayed than PD-L1. I don't know what happened because he was seen by the neurosurgeon. Yes, I remember the story. He was seen by the neurosurgeon. They resected the tumor. The tumor was sent to the pathology department. It was sent to the CNS. Here, the pathology department, they're not doing. The pathologist is not doing all. They're doing it by specialty. So the biopsy went for the CNS people. So yes, they released the report, it's adenocarcinoma, but they did not send for NGS or PD-L1. So when we saw the patient in the clinic, he came after debulking, he came after radiation. The result, the pathologist showed adenocarcinoma, but nothing more. So he was having bilateral lung disease, but nothing in the abdomen, nothing in the bone. Again, his performance was very good. So we started chemo, carboplatin, Alimta plus pembrolizumab. I gave him 3 cycles with very good disease control, and the most important, the very good tolerance. So he was doing very well. As I mentioned, his son is a physician. He used to just update me about the general condition of his dad, like he's doing well, no respiratory symptoms. There were no much of respiratory symptoms, but at least he was not, the chemo was not touching his quality of life in a bad way. So after 3 cycles, he underwent staging workup, and there was significant improvement. After 3 cycles, I received the result of his PD-L1 and NGS. There was no targetable mutation, so NGS was negative. and the PD-L1 was 80%. So immediately I omitted here, especially the disease burden was not that high. If the disease burden was big and the patient having symptoms from the disease, I would continue for 6 cycles of the combination and then omit the chemo and then continue with pembrolizumab single agent. Here I just omitted the chemotherapy. I did not even continue with Alimta single agent for maintenance. I just continue with pembrolizumab. You can see here this his CT in 2020 and his CT in 2023. I saw him 2 months ago. He is very good. He's doing great. No evidence in this of disease. He had recent PET CT scan, and I forgot to bring it to you. But his last CT scan was 2 months back. He was doing very well. And the brain, there is no relapse in the MRI. So what is the plan for him? We will continue till 2 years if there is no toxicity. And then I will discontinue pembrolizumab and continue surveillance. I don't usually go beyond 2 years in immunotherapy. The toxicity that he developed was, of course, hypothyroidism. Most of them, they develop hypothyroidism, and he developed adrenal insufficiency at some point. I'm very skeptical now about his prognosis because we have to give steroids, and this might affect the action of the immunotherapy, might interfere or might make the patient less sensitive to immunotherapy. But we have to replace his adrenal cortisol. So from where did we get this data? How did we reach this data? From where did we say that? How did we reach this? How did we say comfortably that patient with high PD-L1 can go for single agent, and those below 50% of PD-L1, they should go for combination. So the keynote was the first trial that showed improvement in overall survival and BFS with a single agent. Are you seeing the slides? You see the slide?
نعم.
And I cannot see it actually. So give me a few minutes, please. Sorry, Anna, I was mute. I cannot see my slide. The first 3 slides of the trial, I cannot see them. I don't know, they are blank here. So the keynote was the first trial that showed improvement in BFS and overall survival in patients with high PD-L1 when they used pembrolizumab in comparison to platinum doublet or standard treatment. So I think in the first trial, deposition, you can see that the patients were randomized 1-to-1. More than 300 patients were involved. The first arm received chemotherapy, doublet, platinum-based, plus pemetrexed or Taxol according to the معلش ثواني بس أنا آسفة في عندي. Okay, I will use my mobile. So the keynote, as I mentioned, they select patient with a stage 4 non-small cell lung cancer with a high PD-L1 level, randomized to pembrolizumab single agent versus chemotherapy. It depends on histology, pemetrexate in non-squam, and squam they chose taxane. So the overall survival was significantly improved by addition by using pembrolizumab as a single agent, and that was seen in the first follow-up at 3 years, and then the same result was seen at 3 years and at 5 years follow-up. If you look at the overall survival, it was almost doubled by using pembrolizumab as a single agent. And the hazard ratio was really significant. It was 0.6, and this can be translated into 38% reduction in the risk of death. For BFS, you can see also, I'm not seeing which slide I'm talking about. I'm just using my phone. I'm very sorry for that. So for the PFS, again, you can see at 3 years, there was significant improvement in overall in the BFS. You can see it, at 3 years, 4% of the patient in the chemotherapy arm were still having, they were alive and their disease is controlled, while it was like 23% of the patient in pembrolizumab arm were still alive, with a hazard ratio of 0.5, like 50% reduction in the risk of death because of non-small cell lung cancer. So this is very amazing data because, as we mentioned before, the best scenario for patient with stage 4 non-small cell lung cancer was not exceeding 1 year. Here you can see at 3 years, you have almost 1/3 of the patient, like let us say, or 1/4 of the patient, 23% of the patient were still alive. Their disease is controlled. So big difference. With just put in mind, you are using single agent immunotherapy, and you don't give the combination of chemotherapy without significant toxicity like hair loss or neutropenia. So if you look at the objective response rate, no patient reached complete pathological response in chemotherapy arm, while you can see this in around 7 patients achieve that. If you look at stable disease or partial response, all of these were improved with pembrolizumab, not by immunotherapy. So you can say that a patient who completed 2 years. So as I mentioned before, we don't go beyond 2 years. Now in US, they start to ask the patient if the patient is willing to continue, they continue beyond 2 years. If the insurance is agreeing to do that, they go for this. But ideally, you don't go beyond standard of care. You don't go beyond 2 years, even if the patient is having good disease, good tolerance, no toxicity. Definitely, if you have toxicity, you will not reach at 2 years. You will stop it before that. But if you were able to complete 35 cycles, this will improve the overall survival of the patient, even if you stop the medication, because they found that even at the time of disease progression, if the patient progressed down the road after the completion of 2 years of immunotherapy, it says the patient can benefit from immunotherapy in the second line, as a second line in the metastatic setting, and the PFS too will be improved. So you don't miss the benefit of pembrolizumab if you introduce it again at the time of disease progression. So there's no new safety signal. So no No new side effect had been seen. And this trial confirmed that 5 years is overall survival and 5 years of PFS improved with pembrolizumab, and it was the medication was tolerable. So what about other immunotherapy? What about other IO? In Power Lung 1, this is another trial that looked at single agent similimab versus similimab is anti-PD-1. It is the same like nivolumab and pembrolizumab. Also compared to platinum doublet in a patient with PD-L1 more than 50%. More than 300 patients were involved. Of course, we have to mention all those patients who were involved in this trial were lacking driver mutation. Median overall survival was not reached at the time of analysis. And for chemotherapy, the median PFS was 14 months. So the hazard ratio is 0.57. Similimab was having the same side effects, same toxicity. This is itis, hepatitis, pneumonitis, but the patient here, they noticed that they were having much higher toxicity, cardiac toxicity like myocarditis, and pneumonitis and nephritis. So it's a little bit more toxic, but almost the same. And this toxicity grade 3 and 4 were not significantly high. So now similimab is a part of the NCCN guidelines for the patient with PD-L1 more than 50% in the first upfront. So what about atezolizumab in Power 110? Also another study evaluating first-line atezolizumab in comparison to platinum doublet. Atezolizumab is anti-PD-L1. And again, patients who are they don't have driver mutation, patient with PD-L1 more than 50%. Again, the other arm was a standard chemotherapy, cis or carboplatin plus pemetrexed, cis or carbo plus they use gemcitabine, not taxane here. And this is a little bit strange. Usually, I don't know what is the practice in Sudan. I think it will be the same. We used taxane in the. Do you have any comment on that? What are you using, guys, with a platinum doublet? With carbo or cisplatin? What do you use commonly? Carboplatin or cisplatin? Hello.
We use cisplatin, but accordingly, the patient performance and other, sometimes use carboplatin.
Okay. Thank you. And usually I go for carboplatin. I don't like cisplatin because of toxicity, but we're not using gemcitabine in the first setting. We use taxane if the performance is good. Then the patient after few cycles or like 6 cycles, the standard is 6 cycles, then maintenance. If the patient are squam, they go for just surveillance. If the patient are adeno, they go for pemetrexed maintenance. And for atezolizumab, they continue till disease progression or completion of 2 years. So the primary endpoint was overall survival in patient without driver mutation, of course. So they look at it. They look first at all patients with high PD-L1 expression. Then they look to the patient with high and PD-L1, high and intermediate PD-L1, and then they look at the patient with low PD-L1. Sorry, any PD-L1 expression. So they start from patient with high PD-L1, and then they go down and look at the overall survival with the patient with high and intermediate, and then they look at the intention to treat population, i.e. all the patients with positive PD-L1. So you can see here patient with wild type, because they enrolled some patient with driver mutation. There are patients with EGFR and ALK mutation. So you can see here patient with high and intermediate expression, the overall survival was improved. The overall survival was 16, while it was 12 months for patient with who went for standard chemotherapy arm. For patient with any PD-L1 expression, overall survival was 18 months or almost 19 months. For atezolizumab, while it was only 13 months, like you can see, like 7 months or 6 months difference in the overall survival with a very significant ratio. So even the patient with low PD-L1 expression, they did better with atezolizumab single agent. They did better than having than those who received platinum doublet. I think this is just a repetition of the slides. So, of course, patients who have high PD-L1, the PFS was also improved and overall survival was also improved. There was no difference actually in the response between the squam and non-squam. So in comparison, all of them, they have improvement in overall survival, improvement in PFS with a significant hazard ratio in all. So the conclusion of this trial, atezo was better than immunotherapy in terms of overall survival, better overall response rate and duration of response in a patient with high PD-L1 and the patient with intermediate or even low PD-L1 expression. Now, atezolizumab is a part of NCCN guideline in the first line for patients with high PD-L1. Regardless of the histology, this is very important. So what about combination of chemotherapy? So as we mentioned before, who are those patients who will go for combination of chemoimmuno? Patients with PD-L1 between 1% to 49%. So any patient at this level should go for combined chemo plus immunotherapy, and you don't go for immunotherapy as a single agent. If the performance status of the patient allowing you to go for that. Very important, guys, to have a low threshold to think of the toxicity and of immunotherapy. What I want to say, immunotherapy is not safe. Don't get excited by the result of the trials. You have to think carefully. Yes, it is not chemo. There is no immunosuppression. There is no hair loss. There is no nausea, vomiting, but there are really serious side effects. There is a hepatitis. We lost one patient at the beginning of the early when we start use immunotherapy. We lost one patient because of hepatitis, because she came to ER. Nobody knows that this is immunotherapy induced. It was in the early era of immunotherapy. You have to think of hepatitis. You have to be very generous in using steroid once you think in this is immunotherapy induced hepatitis. Pneumonitis is a very serious side effect. And always if the patient comes to you in the clinic complaining of fatigue, constipation, weight gain, you have to think of thyroid problem. Most of them, they develop, the majority actually, they develop hypothyroidism. Some of them, they might develop hyperthyroidism, but the majority will have hypothyroidism. So I recommend to have thyroid function every 3 cycles. This is this is what I'm doing in the clinic. We don't have clear guidelines. The guidelines is saying you have to observe, but how frequent, it depends on your practice. But for my practice, I'm doing it every three cycles if possible, or whenever the patient is having symptoms. So combination of chemo plus immunotherapy, we have the Keynote 407. Keynote, they look at the patient with squamous cell carcinoma. They took the pure squam histology. They use pembrolizumab plus chemotherapy versus chemotherapy without immunotherapy. So, and the primary endpoint was overall survival. So this trial met its primary endpoint. Is this slide clear? Hello? Is this slide clear, guys?
No, not clear.
Yeah, and I think I committed a mistake and I prepared it في Mac, but then I just move it to other laptop. Do you have it in your mobile, البرزنتيشن ولا لا؟
لا لا ما عندنا.
طيب let me So this is a slide about overall survival in intention to treat population. So all population, they look at the overall survival. So at 2 years, first of all, they notice early separation of the curve. And this is very important. Why the early separation of the curve? This is a very crucial point. Early separation of the curve means the medication in the or the comparator or the new medication has effect from day one. So if you notice late separation, like for example, if you are giving chemo plus immuno and the other arm is only chemotherapy. So you notice early separation, it means this immunotherapy has effect. But if you did not see any separation of the curve, it means the chemotherapy is similar like chemo plus immunotherapy. But here you can see the effect of immunotherapy, pembrolizumab from the first cycle. So the curve here separated very early at 12, and I will mention to you the numbers here. At 12 months, the overall survival in Pembro arm was almost 65%, while it was only 50%. With the follow-up at 5 years, the patient who received Pembro plus immunotherapy, about 19% of them were still alive. Well, that was seen in 10% of the patients who received chemotherapy only. So we can say that overall survival had been doubled by using Pembro in combination, in addition to immunotherapy. And the hazard ratio was 0.7. So you can say that there was 29% reduction in the risk of death. Oh my God. I think you're not seeing this slide, صح? This one was not also clear, صح ولا?
Yes, we have not seen.
So anyway, you will receive this presentation, but then I will comment about that. Let me see the rest of the slide. Okay, very good. But only this slide maybe. So about PFS, the PFS was also better in the patient who received pembrolizumab. PFS at 5 years was 10% of the patient were having disease control, while only 3 or 4% of the patient, their disease was controlled at 5 years, and the hazard ratio was 0.62. Again, the PFS had been doubled, and there was 38% reduction in the risk of progression. So this is when they add pembrolizumab to the patient with squamous cell carcinoma. So tumor response, you can see that there is a big difference in the response if you compare chemo to immunotherapy, regardless of the PD-L1 level. So even the patient who has PD-L1 of less than 1%, still the response or the tumor shrinkage was better than the patient who received chemoimmuno. They have good disease control, even if their PD-L1 was less than 1%. So of course, patients with PD-L1 more than 50% were the best responder, but that means even patient with 1 or 5%, if you give him immuno plus chemotherapy, he will do better than the patient who received chemotherapy only. So Bimbro plus pemetrexed platinum meant and Bimbro pemetrexed platinum maintenance overall survival. So they allowed a patient with non-squam, squam, sorry, they allowed to receive Alimta plus immunotherapy. Patient again who are have a squamous cell carcinoma, they just left without any maintenance because you cannot continue on Taxol for life. Patient who completed 2 years of pembrolizumab, they have improved PFS, improved overall survival, and again they did well when they look at their PFS too. So now the standard of care for patients with non-squam is to give combination of immunotherapy plus chemotherapy if the PD-L1 is less than 50%. And of course, again, no driver mutation. So what about patients who are having PD-L1 less than 1%? So it's like a combination. They look at patient in both trial. The patient who looked at the immunoblast chemo in the squam and immunoblast chemo in non-squam. So they look at both trial and then they look at the patient with PD-L1 less than 1%. So here they give the patient immunotherapy, the other arm received immunoblast chemo, the other arm received chemotherapy, the standard of care. Of course, patients were having low PD-L1, patients with high PD-L1 were excluded, patients with driver mutation were also excluded. So the overall survival, you can see here, at 5 years, overall survival, we can say that 13% of the patients were still alive, while only 9% of the patients in the chemotherapy arm were alive. And you can see the early separation of the care from the beginning, from the first few cycles, the patient showed better disease response and better disease control when Bimbro added to chemotherapy. And the hazard ratio for that was 0.6. So BFS was also improved. You can see 4.6% of the patients were alive and 3.7% were alive at 5 years, putting in mind there is difference, although it is mild difference, hazard ratio. Statistically, that was significant at 5 years, but put in mind those patients were having PD-L1 less than 1%. So the difference is small, but if you think those patients might, in other areas, they might not be eligible for receiving immunotherapy plus chemotherapy because their PD-L1 is low. But real scenario, those patients still they can do well if you added Bimbro. So the bottom line or the lesson here, if you have the chance to give immunotherapy to chemotherapy, that will be good. That will improve the PFS and will improve the overall survival of that patient. And especially in a squamous type, because giving maintenance might improve PFS and it might improve the PFS too. So leaving the patient without treatment, usually it's a little bit difficult. In patient with adenocarcinoma, you can continue with Alimta for a good time. One of my patients received Alimta for more than 50 cycles without significant toxicity. But think of a squamous cell carcinoma where you cannot give chemo beyond 6 cycles. So you can leave them just alone without any maintenance. Here it's a little bit difficult. So if you have the chance to give them maintenance immunotherapy, that would be better. And you will not be able to give them maintenance immunotherapy if you did not start it from the beginning. So you cannot just give chemo and then switch to maintenance. So this is not maintenance, this is like a second line. If you don't have the chance to start it from the beginning, you just leave it for the second line because the patient might do better in that scenario. But don't do like switch. Better to be started in combination from the beginning with the chemotherapy. PFS2, so PFS2 was better, with hazard ratio was 0.5, like 45% reduction of progression So what about response rate? You can see that a patient with who received chemo plus pembrolizumab, the response rate was better if you are talking about partial response, stable disease. So all of these were better in the, so if you look at the what is that? So the hazard ratio was in favor of giving chemo plus immunotherapy in terms of overall response rate, duration of response. So here we can see 2 months difference in the duration of response, BFS, and overall survival. So durable improvement in overall survival, BFS, overall response rate, and even BFS2, 2 years, of course, this is the best. Those are the best responders. The BFS2 will improve. And the good thing that I'm always mentioning that you can re-challenge them with immunotherapy at the time of disease progression. So they don't lose the efficacy of immunotherapy in the second line setting if they completed 2 years. But of course, don't do that if the patient does relapse very, very fast. Again, we don't have a specific recommendation, but I'm doing it like small cell lung cancer. So if the patient progressed within 6 months, that means he lost his sensitivity to immunotherapy. But if he lapsed for after more than 6 months, of course you can go for re-challenging him with immunotherapy. The bottom line and the other point that I want to stress, and you don't interchange between immunotherapy. So if the patient did not do well, relapse, let us say that you give the patient 2 years of pembrolizumab, and then you stop pembro, and then the patient relapse after 2 or 3 months. You don't go and re-challenge him with another immunotherapy, like, oh, okay, I will use nivolumab because it's different. So the action is the same. The effect is the same. So don't do that. If you want to re-challenge, you re-challenge with the same medication. If the patient relapse in less than 6 months, I don't recommend to re-challenge with immunotherapy. You think of another chemotherapy. The third point, which is very important, we need to stress, always think of doing rebiopsy, because we know those patients might develop another mutation. They might develop transformation. So transformation, usually we see it common in patients who are receiving targeted therapy, mainly the patient with EGFR mutation, while they are in third generation, for example, Tagrisso. So you might have MET amplification, you might have transformation to small cell lung cancer. I have one of my cases. She was on Tagrisso for 3 years, and then she had disease progression. So when we repeated the biopsy, it was small cell lung cancer. So always think of, if the patient has no mutation before, and you have full NGS and it was negative, always think of doing a rebiopsy. If I'm asking you in a clinical case scenario, and I told you now the patient had disease progression in the first line setting, what are you going to do after that? I would be very happy to listen that you will think of, even if you cannot do it, but at least it is in your mind. So when you are in a place where you can do it, you will not miss that. How do you do that? You do it by tissue biopsy if you can. If the patient general condition allow you to get another tissue biopsy, that would be great. If you cannot, you go for liquid biopsy. You look at it's a blood sample. I know it is difficult sometimes to do it everywhere, but this is how we can deal with a patient when you cannot get another tissue biopsy. But always think of having tissue biopsy. So the Empower 130 study, this is a combination of atezolizumab plus carboplatin in a patient who are chemotherapy naive, so stage 4, no previous line of therapy. They stratified patient by gender, baseline, liver, there is liver metastasis, no liver metastasis, and PD-L1 level expression. So they give atezo, carbo plus nab-paclitaxel And the other arm, so randomization was 2-to-1. They gave carboplatin plus paclitaxel, not paclitaxel, sorry. So the standard of care, and the other arm received atezolizumab plus the standard of care. And then the maintenance was atezo, and again, patients who were having squamous subtype received best supportive care, and then or surveillance. And the patient with adenocarcinoma maintained on pemetrexate every 3 weeks. So until disease progression or completion of 2 years. So the primary endpoint was PFS and overall survival. Secondary point were also overall survival and PFS in intention to treat population, so all patients. So here you can see that in intention to treat population at 6 months, you can see a patient who received atezo chemo, and PFS was 56%, while it was 42% in the chemotherapy arm, and in 12 months, it was again doubled by addition of Bimbro to chemotherapy. You can see the separation of the curves. You can see that the hazard ratio was 0.6. The overall survival again at 2 years, 39% of the patient or 40% of the patient were alive, while only 30% of the patient who received chemo only without immunotherapy were alive. And the median overall survival was 19 months. I'm always reminding you that the overall survival without immunotherapy for those patients without mutation was not exceeding 1 year in best scenario. So the median here was like 14 months. What about secondary endpoint? Investigator assessed PFS and overall survival. So it's not only by the it's by investigator and committee. So you can see the PFS and overall survival again were also better with atezo in combination with chemotherapy. So there was almost like 7 months difference, and so 5 months difference in the overall survival. So, but what about looking at the PFS in consideration to PD-L1 level? Here in the right, in the left side, you can see the patient with high PD-L1, in the middle patient with PD-L1 low, and in the right side, you can see patient with almost PD-L1 0. And just I want to draw your attention, just looking at the hazard ratio, you see patient is still having benefit when the PD-L1 is 0. So atezo plus chemo improve PFS even in patient with 0 PD-L1. Patient with low, of course, have improvement in overall survival, and the patient with high PD-L1, the hazard ratio was 0.5. Looking at overall survival by PD-L1 status, here you can see again the same distribution, low, 0, and high, and hazard ratio was also improved, but the best achiever were here when actually the patient with low or intermediate level of PD-L1, they did better even than the patient with high PD-L1. The patient with high PD-L1, the overall survival actually was not that impressive. And I think this can only be explained by the trial design. So we can say that atezo plus immunotherapy improve overall survival and PFS in patients even with very low PD-L1 expression. Sorry, I cannot see this slide. Just so can you see the previous slides? What do you have here? Do you see this slide, guys? Hello?
No, we haven't.
And here, no, huh? So you're not seeing like 4 slides, 5 slides?
Yes.
I'm very sorry for that. طيب. Salah, can you send it to their mobiles? I don't know. Can you open it from the mobile ولا لا? From WhatsApp. And I can mention it, but I want you to see the trial. Here we're talking about 9LA trial. 9LA, really I was very skeptical about this trial because you know what they use. Again, here we're talking about, still we're talking about patient with low PD-L1. So the standard of care is to combine chemotherapy plus immunotherapy. Okay, we saw the benefit of atezolizumab in combination with standard chemo. We saw the pembrolizumab with the standard of chemo. But here, what they do is addition of 2 immunotherapy plus 2 chemotherapy. So like 4 medication. So this was very challenging. Well, the medication that had been added was ipilimumab. So nivolumab, we know that nivo was the first immunotherapy that we used. And I feel very safe, very comfortable while I'm using nivolumab because it's the first medication that I use. Toxicity is not that bad, tolerable. But when you add it to ipilimumab, you are always think of the ipilimumab when it had been introduced and used in melanoma. So you can remember that the ICU admission, the toxicity profile, patient who died because of ipilimumab. So it was not a good experience. The dose which was used in melanoma was, I think, 3 milligram. Here they just used 1 milligram. So it was used in the first line setting. I'm gonna mention it verbally, sorry for that, but you will have it all in the presentation. So 2 arms, arm 1 and arm 2. Arm 2 was the standard of care, the platinum doublet. Arm 1 was immuno 2, dual immunotherapy, nivo ipi, and plus the standard of chemotherapy. So ipilimumab was used in a small dose. So it's not the dose which was used in the melanoma. So it was 1 milligram per kg. So just like they're saying baby ipilimumab. So very small dose of ipilimumab. How was it given? They gave like 2 cycles only of chemotherapy. And that was the beauty of this trial. So they did not use chemotherapy that much. So they give nivo every 3 weeks. And then they give ipilimumab every 6 weeks. So the cycle 1 will be nivo, epi plus dual chemotherapy. When the patient comes to cycle 2, he will get chemotherapy, but he will not chemo plus nivolumab, but he will not receive ipilimumab. So when the patient comes to the next cycle, so he will just get ipi again plus nivolumab and no more chemo. So chemo for 2 cycles, and then the patient will be maintained on nivo ipilimumab. So maintenance nivo epi. In the other side, in the other arm, it is like we mentioned before, Alimta or pemetrexate maintenance or surveillance for patient with squamous cell carcinoma. So just remember that chemo was given for 2 cycles only. Patient who received dual immunotherapy, immunotherapy was maintained until disease progression or unacceptable side effect. So nivo plus epi, if we look at the overall survival, at 4 years follow-up, overall survival was 15 months, 15.8, sorry, 16 months in the nivo plus epi, and it was 11 months. So there was 5 months difference in overall survival with a hazard ratio of 0.7. They looked at PD-L1 expression in relation to overall survival when they use this combination. So again, patient with low PD-L1, they benefit from nivo-epi plus chemotherapy. They looked at the histology, squam, non-squam, all of them, they had the same improvement in overall survival when they use dual immunotherapy with a standard chemotherapy. The duration of response, yes, it was better. Duration of response in patient with PD-L1 more than 1%, so very low expression. There was a 6 months difference in the duration of response, or you can say it was double because it was 12 months and 6 months in the chemo arm. So the duration of response was better in patient with low PD-L1. So even patient who did not tolerate that, and there is a very nice curve, please look at it when you have the presentation. Even the patient who did not tolerate, even the patient their treatment had been discontinued, they continue to benefit from the medication that they received. So when they look at the patient who did not tolerate the immunotherapy, they just stopped it and they completed the chemotherapy, and then they stopped the chemotherapy or maintained on pemetrexed, and they compared them to the patient who just only received the other arm, who received only chemotherapy. There was difference in the overall survival and PFS. So those patients continue to have better PFS even after discontinuation of the treatment. So at 4 years, follow-up patient treated with nivo-ipi plus chemo continue to have long-term durable overall survival benefit. So, and magnitude of benefit, as I mentioned, was seen in a patient regardless of PD-L1 level and regardless of the histology. So the discontinuation did not affect or did not impact PFS or overall survival negatively. So at 4 years, 27% of the patients were alive and continued on treatment. And I think recently we have another update for this trial, and it was still positive. The patient who received after of discontinuation, when we talk about 4 years follow-up, it means that those patients, they are not getting treatment, because we know we don't exceed, as we mentioned many times before, we don't exceed 2 years. So those patients off therapy for 2 years, still you can see 27% of them still alive. This is another trial of nivo plus ipilimumab. So the medication, the combination now is safe. They continue to use the same small dose, which is 1 milligram per kg. So it was checkmate 2227. And here we're gonna just talk about the part 1A. So the trial has 2 arms, stage 4, and no prior systemic therapy, no mutation, patient with good performance status. They allow patient with CNS metastasis, and this is very good, because most of the trial they are excluding patient with CNS metastasis, so they don't allow them. So most of the trial, they did not tell you what happened to those patients. They just take them out of the trial. They don't enroll them. But here they enroll patient with controlled disease, at least, like treated or not treated, but it is controlled. So part 1, a patient with PD-L1 more than 1%. So they do have positive PD-L1, around 1,200 patients. The arm 1 has 3 arms. The first arm received nivo plus epi. The second arm received chemo only, and the third arm received nivo only. So the arm 1B, it was nivo plus epi and the chemo again, but the third arm nivo plus chemotherapy. Just to draw your attention, when the patient are having a PD-L1 less than 1%, they don't allow to give nivo as a single agent. If you look back at the upper arm, 1A, they allow nivo as single agent. But here, when the PD-L1 is less than 1%, they just give nivo plus chemo or chemo as single agent. So here you can see chemo single agent, but in the 1A, you can see single agent chemo, single agent nivo. Okay. So the primary endpoint was PFS. They look at tumor mutation burden, and exploratory analysis, they look at overall response by response and tumor burden reduction, and overall survival by quality of life. So nowadays, it's very important to comment about the quality of life of the patient in any trial, because again, this is a stage 4 disease, and your intention of treatment is palliative or just improve the quality of life, improve a PFS and overall survival if you can do that. So overall survival in patients with tumor more PD 1% improve the of Nivo plus epi. Just as I mentioned, we are looking as a result of R1A. So Nivo plus epi, this is the red line. You can see at 6 years, there was the 22% of the patient, the disease was still under control. The green was Nivo, single agent, and the gray was chemo. So you can see the difference, although Nivo was used as a single agent, still we can see the difference in the overall survival. So Nivo plus epi at 6 years showed 22% disease control. Nivo as a single agent at 6 years showed 15% disease control, overall survival, and for chemo only was 13%. So the hazard ratio for Nivo epi was 0.7, Nivo as a single agent 0.9, and for chemo is not significant. What about duration of response and PFS by tumor PD-L1 expression? So if you look at the duration of response when the patients have PD-L1 more than 1%, very clear, Nivo plus epi, duration of response was better. And even in patients with low PD-L1, we saw the same mirror image, improvement of duration of response was longer with Nivo epi, and those with chemo, they did not do well, actually. So what about overall survival? Just looking at them, look at this 3 water plot. So in the first one, to your left, you can see Nivo plus epi. In the middle, you can see Nivo plus chemo. And the last one, or at your right side, you can see chemo only. So the deeper the plot, the deeper if you're looking at the first one on your left side, Nivo epi, you can see the dark red, 8% of the patient. The 8% of the patient, it means those patients were having no evidence of disease. So the disease was like completely, those are the patients who had complete response, complete radiological response. 16% those who had almost partial response, and 12% who have the gray one is a patient who continue to have at least a stable disease. So you can see very good response, like the dark red one, the one that showed 8%. Here they have disease control more than 80%. So this is very amazing. And 16% achieve response between 50 to 80%. You can see 12% have response between 30 to 50%, and the gray color, you can say they have stable disease. So the same, you can see that, but here, if you look at the patient with disease response or complete response, if you can say it, or more than 80%, the number was a little bit smaller, but it's still it's very acceptable. Like 6% of the patient had almost complete radiological response. If you look at the chemo arm, you can see that only 1% of the patient had this. So put in mind here, we are looking by PD-L1. But still, this is like was exploratory analysis, but we have to consider it. So another immunotherapy. So now, if you had the choice, when can you apply this trial? Let us comment about this. If you had the combination of both medication available at your site, if you think the patient can't tolerate this combination, if there is no contraindication, you have to know the contraindication when you should not go for combination of chemotherapy, immunotherapy, when you should not go for immunotherapy. Patients who are having active autoimmune disease, you should not go for that. So you have to know the contraindication of immunotherapy. So you have to know your limitation. So the patient with very poor performance status who cannot go for chemotherapy, it's very safe to give them a combination of chemotherapy if there's no other contraindication, if you have the medication available. So those patients, they tolerate the treatment very well. Quality of life, when they looked at it, I don't have the slide here, but the quality of life maintained all through the treatment and for 2 years. So the combination did not change their quality of life. So tolerability was good, new safety signals, and improved BFS and overall survival. So if you have the chance to give the combination, that is good. If you have the right patient, that would be great. So another medication that is similimab, and just mentioned that it is anti-PD-L1. So similimab was given, again, the same copy-paste trial. Now we're talking about first-line treatment without mutation, simi plus chemo. The other arm was chemotherapy alone. For squam, they did not use pemetrexed. They enrolled around 1,000 patients. So looking at survival data here, this slide is busy and small. I don't know if you can see it well, but if you look here, you can see the hazard ratio was in favor of using semi plus chemotherapy in all patients, in all histology, in all PD-L1 level. Patients with good performance status, they do better. And this, I think, can be explained by when the patient performance is good, you can continue. If the patient performance is not good, you might go for dose interruption or delaying the treatment. So, but here you can see the hazard ratio is in favor of giving immunoblast chemotherapy. Overall response rate, so overall survival story was better. This was like early result at 12 months. Overall response rate was better, and PFS was better with semi plus immunotherapy. Tumor response rate, yes, you can see the pink color is semi plus chemo, while the blue color is chemotherapy only. And here you can see the very big separation between the two curves, chemo and immune arm. So the median overall survival was almost 2 months, while it was what chemotherapy was only 13 months with a hazard ratio of 0.7. So the subgroup analysis showed that overall survival was similar in the patients with low or high PD-L1 level. The serious adverse event was only seen in 25% of the patients with similimab, and it was not something new. It was again pneumonia and neutropenia. Yeah, definitely neutropenia during the first period when it was combined with immunotherapy. Poseidon trial, this trial, they look at tremelimab plus durvalumab plus chemotherapy, again, dual immunotherapy and dual chemotherapy. In a first-line setting, it's almost similar like Checkmate, a trial when they combined nivo plus ipilimumab. So 1,000 patients lacking mutation in the first-line setting. So the three-drug combination was tolerable and safe, and give improvement in overall survival, and PFS, and the hazard ratio was really significant, was 0.7. So this is distribution and deposition of the patient in the Poseidon trial. So as I mentioned, more than 1,000 patients. First arm received immunotherapy, dual immunotherapy plus chemotherapy. Second arm received durvalumab, one immunotherapy plus chemotherapy, and the third arm received chemotherapy only. Here you can see the overall survival. They compared durvalumab plus immunotherapy to chemotherapy. Durvalumab, there was the overall survival improved with the addition of durvalumab to chemotherapy, and the overall survival is better with dual immunotherapy plus plus chemotherapy. The hazard rate for durvalumab ipilimumab chemo was 0.7, while it was 0.8 in durvalumab chemotherapy. So the subgroup analysis showed improvement in overall survival. Again, if you look at classification, gender did not affect the response. Age, so patient below 65 and above 65. Always we used to say that elder patient, they don't do good with immunotherapy, and this can be explained by their weak immune system. But here you can see that there was no difference in between patients above 65 and below 65, regardless of PD-L1. The subgroup analysis, the overall survival in favor of giving dual immunotherapy plus chemotherapy. If you looked at the chemotherapy, there was no difference between using gemcitabine, nab-paclitaxel, or pembrolizumab. Patient who never smoked, they did not do well. And this is, do you have any comment on that? Patient who never smoke, they don't do well. Can anybody comment about this? So the idea of immunotherapy, why we use it in patients who don't have target, or they don't have targetable mutation, because the number of mutation here is limited. Patients who did not smoke, they do have limited number of mutation. But patients who are smokers, they do have number of mutation. Usually their tumor mutation burden is high. PD-L1 usually is high. So the response, that's why you see the response, better response in a smoker patient with immunotherapy. The opposite exactly when you use the targeted therapy in a patient who was a smoker, they don't know. That's why you don't see the mutation in a smoker patient. So this smoker usually they're lacking, most of them they're lacking the mutation. You don't see it you see it more in the female, because previously the history of smoking was not comparable. Now it's comparable between male and female. You are not expecting to see much targetable mutation in the smoker. That is why this is the only thing that can explain why, because the PD-L1 higher and the tumor mutation burden is higher in the smoker. And this can explain why they do better with immunotherapy. So if you look at the patient who are currently smoker, they did very well. The former smoker did also very well, while the patient who never smoked, no, they did not benefit that much from the immunoblast chemotherapy. Regardless of the age, the race, ECOG performance status 0 to 1, brain metastasis does not affect the overall survival. So the updated one, I think you still will be having a problem with this slide. The updated overall survival showed that patients who received dual immunotherapy plus chemotherapy did better than patients who received chemo only. So grade 3 and 4 was seen, but I think it was not that much. Most of the patients had grade 1, grade 2 manageable side effect. Okay, I think this was the last slide. Thank you so much. And sorry for the long presentation, but I tried to make it short as much as I can. I know it's very tough, too much, but I think we had the most important trial. You just go over them. Almost they are similar. They copy paste. We're talking about the same type of patient. In conclusion, you can say that all of them, they had PFS improvement and overall survival improvement. You go back and revise the medication, the name of the trials. Toxicity profile almost the same. The management of toxicity profile is the most important, and you have to know it very, very well. So this is what you need to know in regarding the chemotherapy in the first line setting. Yes, question?
I have question.
Yes, please.
Thank you for very nice and clear presentation.
Thank
As
you.
we saw, when use anti-PD-L1, even when combined score less than 1, there is a benefit in form of overall survival, progression-free survival. My question, can we use anti-PD-L1 regardless to do a test? Especially in Sudan, we have no availability of
Yes.
the test here.
Yes. Actually, this is a standard of care. You can use it regardless of the test. If you cannot do the test, you can go ahead and do that. But you have to exclude NGS. You have to exclude targetable mutation. So it's very important, very crucial to have NGS. But if you cannot do PD-L1, you might not do that. So at least for the first cycle, 6th cycle, you can give the combination. For the maintenance, still you can maintain. There's no guidelines for this, but I will give you my advice. If you can do NGS, do NGS. If you cannot do NGS and you cannot do PD-L1, just go for chemotherapy. Okay. So if you can do just NGS, you cannot do PD-L1, give combination of immunotherapy plus chemotherapy and then maintenance. Try not to remove Alimta in a patient with non-squam. Continue Alimta plus immunotherapy in a patient who are non-squam. For squam, you can maintain them on immunotherapy, but put in mind those patients, better definitely than nothing, but put in mind those patients might be having low PD-L1, but still remember in the trial, as we saw, they do very well. So just do NGS if you can send it outside. If you can do it liquid biopsy, you have to make sure that the patient, because they don't do well with immunotherapy and they do have very bad toxicity. This is what we see in practice, by the way. I hope I answered your question. I know it is very tough, especially in Sudan, but safety is important.
Yes, quality of life important.
Yeah.
Yeah, thank you.
Any other questions? أنا I'm sorry يعني I just see your message إنه أنت الصوت ما كان واضح. Anyway, you will get the whole presentation and I send it to صلاح وصلاح هيرسل لكم إن شاء الله. ولو في أي سؤال, if you think إنه you are not ready now to يعني if you have question, yes, I'm open to any question, but if you want to send it by email or by WhatsApp, I'm ready to receive your question. And just feel free.
Thank you so much.
Thank you. Good luck إن شاء الله. See you soon في another presentation وبالتوفيق إن شاء الله لكم يا رب العالمين. السلام عليكم.